section head of pediatric infectious diseases. In addition, I'm also the associate medical director at CADM Lab and a medical microbiologist. So when I hear about and want to get to share about syphilis and the other STBBIs, it's always exciting because it actually merges both of those roles quite well. Because CADM Lab is a public health lab for the province. We do all the testing. And then from a pediatric ID perspective, I've had a longstanding issue in HIV in children and prevention of transmission to babies from pregnant women. So this will be a good opportunity to go over some of that. But I think that the crux, or what people wanted to hear about mostly, was syphilis. Is that correct? Because that's something that you absolutely get bombarded with. We do as well. And I will talk a little bit about kind of what has led up to this point. I appreciate the date on that as May 18th. I had given a similar talk to the Manitoba Pediatric Society. So no, this is for you guys, but a little bit of modifying. So first, of course, we acknowledge that we are on the ancestral lands, Treaty 1 territory of the Anishinaabe, Cree, Oji-Cree, Dakota, Dene people, and the national homeland of the Red River Métis as well. Yesterday being National Indigenous Day was an important part to really work toward reconciliation for the harms of the past and hopefully making a difference in the present and future. So I do have some conflicts of interest, but ultimately I don't really think it's going to impact a lot of what we talk about today. So I have several roles now due to our experience here with syphilis at national level. So I'm the chair of the syphilis group for the National Advisory Committee for STBBIs. And so that really entails a lot of kind of changing policy at the government level, which eventually comes down to the clinical level. I am the co-principal investigator on a study through the Canadian Pediatric Surveillance Program, looking at congenital syphilis. If anything, that actually provides me with more opportunity to study what's going on across the country and see what differentiates us from the other provinces. And then I'm also the co-chair of the Syphilis Diagnostics and Congenital Syphilis and Pregnancy for the Canadian Public Health Lab Network. And again, that's really an opportunity to talk about what diagnostics we use, what could be reconsidered going forward. So before you guys came to Manitoba, did you guys see any syphilis? And how many syphilis cases do you guys think you see in a week now?
I don't know if we can give a rough number, but there will be confirmed maybe 1 to 2 per month. But like between suspected investigations, we are seeing almost like 3 per week or 2. I don't know if this are valid numbers.
No, I think that would be accurate, to be honest. I mean, the NICU, you see them. Absolutely, but I would say the majority of them are not that sick and so end up on the normal nursery and then out to the wards ultimately. So, but yeah, 1 or 2 a month, that makes sense to me. And those are usually also where, incidentally, I see the sickest kids with syphilis by far. Like if you see the hydrops and you see hepatosplenomegaly, and then these kids can't breathe properly and they have the diffuse rashes, all of that, right? But the objectives overall really are to talk about what led us to this point. So local, national, and international epidemiology of congenital syphilis will be reviewed. And then we're also going to talk, which is probably the most important part for you guys, as to how to assess the risk to an infant. And what we're going to do there is categorize them in terms of low and higher risk infants, because the approach that we take in those scenarios are different. So when you look at this overall, what you can appreciate is that the number of infectious syphilis cases across all of Canada has increased quite dramatically. It was a little bit lower back in the early 2000s, and then gradually has made its way up. And then you can also see that when we're talking about compared to the change during the pandemic, it seems to have leveled out. Whether or not that's actually true, like a reflection of the number of syphilis cases decreased, or we had significant syphilis transmission occurring and we just weren't testing for it, or people weren't presenting for it, is going to be found soon. I suspect it's the latter, meaning that we were testing for it, but there was a lot of transmission going on in the community that we simply were not aware of. Manitoba had been the champion for a very, very long time. We had these exploding syphilis rates compared to everywhere else in the country. And whenever we would go places, they would always be in awe when we talked about the number of syphilis cases that we were seeing. But it's not, or we're not that far ahead anymore, in that the prairie provinces in general are starting to catch up. And certainly when we look at Saskatchewan, which is just to our west, they are probably the #1 place. And I would say that they have about the same number of cases of congenital syphilis. But what's really important to say is that nationally, we're getting to about 1/3 of the cases are in women. And of course, why that's important is that we have a lot of cases in women who are of reproductive age. And so that has been a pretty significant change compared to early in the 2000s and so on. And we'll talk about that in the Manitoba context specifically. Here you can see as well that what's happened in Canada is that initially it was kind of males predominantly. And why that was is that the gay, bisexual, men who have sex with men were the primary people affected for a variety of reasons, which we will talk about a little bit as well. But with that big jump in kind of women of reproductive age, that's when we started to see a lot of cases of congenital syphilis here in the province as well. With the first case, I believe, was 2015 that we saw. We were very excited about it. We were like, wow, that's really quite odd and rare. And prior to that, it had been 1977 when we had our last congenital syphilis case. So the novelty has completely worn off, to be honest, at this point. So this is actually Manitoba data. And so you have this huge, broad timeline to look at. And it's really neat because if you look at #1, represented by the red arrow, that's actually before and right around the introduction of penicillin. And so you had a lot of these people who were across the oceans. They were having a lot of casual sex. And as a result, they were bringing syphilis back to Canada. And sure enough, Manitoba was really not immune. But once we actually had the introduction of penicillin, an effective treatment, we saw those numbers drop down quite a bit. Sure, by the 60s, with the sexual revolution, you had a little bit of a bump up again. And it wasn't until we get to 2 in the early 2000s where we start to see pretty significant activity once again. Why that happened for #2, and if you've been in Manitoba, you've maybe heard these stories, is that there was a lot, again, of casual sex going on in the bathhouses in Manitoba and in Winnipeg. And in particular, this was primarily in the gay, bisexual, and MSM population. And so this was a little bit easier to deal with from a public health perspective because you could actually go to the bathhouses, you could actually get the testing done. And in general, I would say the GBMSM population as a whole is very receptive to public health, primarily due to HIV and what was going on back in the 70s and 80s. And then along came the next wave, and that was in the early 2000 teens, so 2012, 2013, and there was a big uptick again. This was a little bit different. And why I say that is because now, again, it was primarily being driven by GBMSM, but instead of meeting in bathhouses and actually having the ability to do contact tracing, this was related to apps and the internet and casual hookups and anonymous sex. So now you had people who had casual sexual contact and they didn't know the names or the contacts and they weren't able to track them down from a public health perspective. And so that really led to a lot of transmission ongoing, because if you can't do contact tracing, that's one of public health's main tools to use to be able to prevent those transmissions and reduce cases. And of course, when you have gay, bisexual, and MSM, you're going to have some degree of transmission into the heterosexual population. And that's actually what occurred as well. You start to see that transmission increasingly into the population to result in what we see now. This giant spike at levels far, far higher than anything we've ever seen is because it's primarily transmitting in the heterosexual population, whereas the GBMSM population is going down. In fact, it's been trending down for a while now. So this is, as I said, primarily between men and women, and in particular, men and women of childbearing ages, and also in people and women in particular who are more likely to have more children throughout that reproductive time. So we're seeing a lot as a result of congenital syphilis. And so what are they seeing across the country? Well, you can see here it was pretty rare where you would encounter any case of congenital syphilis anywhere in Canada. What you see kind of at the beginning of the decade was the tail end of what was going on in Alberta. If you look into the literature, you see there was many, many cases going on there. And so they actually helped guide some of the protocols that we use somewhat, but they did get under control for the most part. But then you suddenly have this big spike again. And so that's predominantly a combination of Saskatchewan, Alberta, and Manitoba. It still remains quite rare in other parts of the country, but we do now, as a result, get calls to Manitoba and the pediatric ID service here to discuss cases when it's seen in places like Newfoundland, Nova Scotia, even Ontario, because they're just not as familiar with it. So this is the breakdown that we have. Every child that is exposed to syphilis in the province has been followed by pediatric ID for the most part. There are some exceptions, and in particular in our northern communities, we have some pretty good people out of Thompson who are following up a number of infants as well. But what you can see here is that, you know what, it started off at just under 50 in 2018. Suddenly we had over almost 150 in 2019. In 2020, we were hitting at about 130 as well. And then last year, we had over 200 cases of exposed infants, with 81 of them having to come into hospital to get treated. So when you're saying you see 1 or 2 a month, we are seeing not unusually, what would that be? Oh, lots, right? 12 divided by that, you've got about 7, 8 per month that we're seeing. That's not unusual.
And there's no way, Jared, that like they can't get an IM depot penicillin like the adults can?
That's a very good question, Chelsea, which we'll talk about when it comes to the treatment and
Excellent.
the history of treatment and where the evidence is, because that's a really important question. What you can take away from this too is that Manitoba currently has a rate of about 482 per 100,000 when we're talking about the data we have through pediatric infectious disease. That's huge. How huge is it though? Well, if you look at the rest of the world, how are we doing? Well, we have 14 on the record as being per 100,000 in Canada. And then you have some places like Texas where there's a fair amount of syphilis. Mozambique, well, we're higher than them, probably by virtue of doing testing more. But Brazil and Colombia do seem to have pretty good testing, and they're not much ahead of us, really. So if we were to say what population this was in specifically, we would eclipse those rates, because it's not like it's everywhere. It is in very distinct populations, kind of in the inner city core in northern Manitoba. And a lot of this ultimately has to do too with the introduction of crystal meth as a primary drug of abuse here in Manitoba compared to what used to be heroin. And so crystal meth is an interesting drug in that it, well, one, you're high for a very long time. And the other thing is you become quite sexually aggressive and far, far less likely to contract for your own safety or safe sexual practices. And so this is why you often see infections in the first place and even reinfections, right? So what about when we're talking about the more specific data from Manitoba Health? Because Santina Lee is one of our former trainees who was involved in the research for congenital syphilis. And now that she is at Manitoba Health and Public Health, she's been able to look at like, what are they seeing and what are they seeing as confirmed cases? And you can see there was 30 confirmed cases, meaning that they had some evidence of congenital syphilis disease. The most common thing you see by far is bone abnormalities, but it can be any number of different things that showed up, whereas probable congenital syphilis were just higher risk infants who ultimately, if we didn't treat within about a month or two, they would progress on to have clinical signs and symptoms. The most important thing I think from this slide to take away is that there is no inclusion of our stillbirths. And stillbirths are a significant contribution to this as well. There are lots of stillbirths as a result, and we've just started to record them. So I think you'll start to see that data coming out in 2022. What I would ask, if you put something in the chat, I might not be able to see it very easily. So if you want, just put up your hand and I can answer questions. I'm happy to do that.
I can read stuff from the chat too if people don't have a mic or something, Jared.
Sure. Sounds good. So how do you assess the risk, right? Like I didn't include this picture. This was Santina's picture that she put in there. I don't really know why. I guess a cute baby, and that baby clearly doesn't have syphilis, but whatever. So one of the most important things that you can do is ensure that all the moms and the babies have paired syphilis serology. That should be relatively easy because all women from 2018 onward have had at least testing in all 3 trimesters. So in the first, second, and third trimester. And if you've had syphilis, you're having far more regular testing as well. But we really need that paired serology at delivery to be able to help us determine whether or not this infant is at high risk or not. What I often find is one of the rate limiting steps is that the infant serology arrives here at CADM Lab and it gets processed and run right away. For some reason, maternal one gets put into not limbo, but it does take longer. And that often leads to low risk women being stuck in hospital when ultimately we're not going to end up doing any treatment. So if you happen to be involved, well, you're more likely to see symptomatic congenital syphilis, so probably not going to happen a ton, but you may have to go to the newborn nursery for an assessment. And if you see one, make sure that's done. Sort out with the rest. That's something that we need to be involved in. And that's why we like to be consultant on all cases, or virtually all cases. There's a lot of push to really turn this into some sort of policy or algorithm. And I really wish it was that simple. In fact, when we're talking about HIV later on, you'll see, yeah, HIV, hepatitis B, Hep C, all very easy. We can deal with that because there's distinct things that you depend on. And the syphilis situation is so complicated that it's not simple to do.
Okay, so if the mom, so again, this is where I'm going to ask the question. So the moms, what's the one that stays positive all the time? Are you going to talk about that? Like, so essentially, if the mom has anything that suggests she may have had syphilis at some point historically, we should send titers on the baby.
Correct. Well, yes, it's not a bad idea. And sometimes so yes, mom will be positive always.
Right.
Oh, caveat.
That's the RPR, right?
No, the RPR might become
Or the
negative.
treponema, something, blah, blah.
I'll back up.
I'll wait, because I know you have a slide.
I will talk about serology right now because I don't actually have a slide dedicated to it. Here at the lab, what we're doing when we're screening for syphilis is we're looking for a treponemal specific antibody, and that's a CMIA, or a chemiluminescent immunoassay. And that is, if that's positive, triggers us to do subsequent testing, including the treponema pallidum particle agglutination, which is also a specific test for syphilis, and then the RPR. We used to do VDRL. Many people at Women's Hospital still call it VDRL. We haven't done it for about 3 or 4 years at this point, but that's beside the point. And that is a lot more useful for telling me disease activity. So when we're talking about the treponema specific things like the CMIA and the TPPA, those are always positive. Once you've had syphilis, for life, that is it. The interesting thing is that you can sometimes be false positives when you have a person who has an infection with Lyme disease, for instance. It's a spirochete, so it's related, and then Helicobacter pylori as well. But what helps us figure that out is the TPPA doesn't tend to be positive in those situations. Whereas the RPR is not specific to syphilis. So you can have that elevated through pregnancy. You can have that for any number of different rheumatological diseases or autoimmune diseases, in particular lupus. You don't run into that very often, mind you, but it's possible. And so that's kind of what we're looking at. We're primarily interested in the non-specific, the RPR itself, and comparing where baby and mom are at. And I'll go into that a little bit going forward. But does that make sense when we're talking about the testing? Okay, I'm getting head nods. Good, good. So those are important questions. If we break it down, these are probably the 4 most important questions. When was mom diagnosed? Well, that is going to be helpful because if it's prior to pregnancy, it probably doesn't mean as much. In other words, if you have a woman who delivers today and she was diagnosed with syphilis in 2019, but she has no risk factors for reinfection, her RPR looks good, in all likelihood, that is an exceptionally low risk infant, and we don't actually even have to follow them. But that being said, women who tend to have syphilis tend to get it again. And so that's something to always keep in the back of our head, and that's why the testing is important. If it's during pregnancy, that certainly is going to place them at higher risk because if they got it later in the pregnancy and we had to treat, and it hasn't been the appropriate time frame for the treatment to take effect in the infant, then we may be stuck as treating the infant as well. And of course, the highest risk of all is we find out they have syphilis at delivery. That happens so much more than you would think because you can see in the notes from the obstetricians, they're way better now, but it used to be, oh, they have a herpes outbreak right now. And then they would ask the women and it's, well, it's not painful. I didn't notice it. And then, of course, we test for HSV and we don't find it. And then the syphilis swab is very positive and you're like, damn. That was syphilis all along. But the stage of infection is also important too, because if you have a woman who is either primary or secondary syphilis, the risk to the infant, if we didn't treat it, is somewhere between 90 to 100%. So that's significant. If it's a latent infection, that's different. It's still high, it's about 40%, but it is considered lower risk overall. So does that kind of make sense? So later in pregnancy, untreated, bad. Primary or secondary, higher risk, bad. Latent, maybe better, but you're never going to find out because, again, a lot of these latent women get reinfected even after we treat them. So you're going, I don't know what this stage is. So that's why I'm saying the algorithm, good luck. Like, there's no way you're going to have all these arrows flowing all over the place. It is a lot more straightforward to say, you know what, did they get treated, right? If it's no, high risk, that's easy. If it is yes, did they get penicillin? Because only penicillin is the acceptable treatment. So if they say ceftriaxone, if they say erythromycin, azithromycin, not good enough. And that's why you'll actually have allergy do a desensitization for pregnant women in order to provide them with this treatment. The number of doses is different. If you're primary or secondary, easy enough. You give them a single dose of IM. We often err on the side of caution and give 2 doses 1 week apart. And then if they have latent, it is 3 doses 1 week apart. If it's neurosyphilis, very, very different. Again, it's going to be prolonged IV therapy for these women, and typically that's administered in the hospital. The fun part is that at this point, I think so many people have had syphilis and they've had these IM penicillin doses that they are a bit scared to come in because IM penicillin hurts. It does have some lidocaine in it as well, which helps numb the pain, but it's not a pleasant thing. And so there's this perception out there that I don't want to get that shot hurts, therefore I'm just going to ignore it. And syphilis certainly does seem to disappear, but it doesn't. It is there, right? The next part is, of course, you want to know is when was the treatment? So is it pre-pregnancy? I was saying that if you had a woman diagnosed in 2019 who received appropriate treatment, then you don't really have to worry to the same degree if you have those nice titer decreases. But if you have a woman who has been treated only 2 weeks before delivery, that's considered high risk as well. That makes sense? Okay. The next part of what we're doing is looking at the non-treponemal titers. So that's the RPR again, and we compare that to when they were diagnosed to when they are ultimately going to deliver or when they're delivering. And we want to see at least a 4-fold drop. And a lot of people really struggle with this math. So for example, if you have someone who's a 1 in 32 RPR dilution, the 4-fold drop is down to 1 in 8, even though that's only 2 steps down. So it's a 4-fold that we're looking for. But if you divide 32 by 4, you get 8. If you divide 64, you get 16. So that's the way to look at it, just making sure that that's what you see. If it doesn't drop by that much, it implies either we got the stage wrong, and so we didn't treat them appropriately. They got reinfected, which seems to be the much more likely scenario, or the treatment was just inadequate in some way, although failure from penicillin is very rare because there is no resistance, not to penicillin anyway. And of course, there's always this risk of reinfection, and this is something that we have really been dealing with a lot. And there's ways to tell. I mean, certainly we can look for serological evidence. And so most of the pediatric ID people will call either Paul Vankesteel or myself to ask, hey, can you look at something here? Because I noticed the RPR, even though it went down, it was 1 in 128, it's now 1 in 32, but it's 6 months later, I would have expected it to go down further. We'll look at the CMIA because it does have a number, a numerical value to it. And what you can see in reinfection is that it will come up a little bit. And so it's a pretty responsive indicator when you have other clinical indicators that, you know, this person may have been reinfected. Usually what I depend on heavily, believe it or not, is seeing, did they get some other STI? So if I see they had gonorrhea and then I see that their CMIA increased a little bit and their RPR is static or not improving, then I go, you know what, they were probably reinfected. So you're gonna have to treat that appropriately or worry about it. A lot of that happens too is because of the risk of reinfection during the month before delivery. Partners tend not to be treated. And if you've gone to see some women who have just delivered, it's not unusual where you walk into the room and They want you to wait until nobody's in the room, including the partner or the father of the baby, or they'll come out of the room with you to talk to you. And sometimes it's an interesting conversation where they don't want either. And you're in the room not using the word syphilis. You're just saying, we're here to give the medicine, and the medicine's going to help. And it's very awkward and strange. So anyway, that's primarily it. Other factors, sometimes you'll have a mom who comes in, delivers, doesn't get any blood tests done, goes back out to the street right away. And that's often a challenge too. And we often err on the side of caution in that scenario as well, if we know they had a prior syphilis infection, because I would say that if their life is that unstable, chances are there's a risk factor for getting syphilis again. So that is kind of the, as I said, that's our assessment process we take. I don't know, maybe there is a way to look at it and make it into an algorithm, but I don't think so, because it's such a, not a straightforward process. But if you disagree, let me know. So what do we consider lower risk? I think
the algorithm is there a positive titer? Call ID.
And I agree with that. I have said that all I really want is make sure the maternal and infant serology is available, and then consult ID. And there are absolutely some general pediatricians in the community who they're good with it now. Like, they get it, and they don't necessarily call us unless they know this kid needs treatment. And even then, like, some of them are starting to get to the point where they'll go, I got this, but follow up, can you do after the fact? So when we're talking about low risk, we mean diagnosed early in pregnancy, they got their treatment, it was at least 4 weeks before, we saw that 4-fold drop, and then overall there's no risk of reinfection. I don't believe anybody. I am a skeptic that way. So I'm not at risk, and you're kind of like, I don't know about that. Unless they say that I have not had sex in the entire time since I was diagnosed with syphilis. And it does happen, right? It does happen. So this is a lower risk scenario. And if we go into this, that's straightforward, right? We know that we don't have to really investigate the baby further aside from a pretty good physical exam. There's no need for IM penicillin or the 10-day course of penicillin. We don't have to do all the different investigations that we typically would do. So this is great. These kids will then go out in the community and we'll do serological and clinical follow-up at 1, 3, 6, and 12 months. So this is a little bit different than when we get to the higher risk infants. And so I'll tell you those differences when we get there. But the idea is that we want to make sure that if this is in fact not low risk, just based on community prevalence, we're on top of it as soon as we can. And that's why the 1 month follow-up is important. Oh, there you go. So when we're talking about this scenario, well, this is a mom that we consider high risk. So they get diagnosed late in pregnancy or at delivery, or they got treated and it was within 4 weeks delivery, so there wasn't time for that to do anything. Was there an adequate drop? Well, if it was 1 in 32, let's say, and it stayed at 1 in 16, probably not good enough, because that actually is within potential lab variation. So it's a partially subjective test, meaning that it's not uncommon to see people that are within a titer of each other. So 1 in 32, 1 in 16, you could have 2 different lab technologists come by and call them that, right? So is there a risk of reinfection? If that's the case, yes, we are stuck and we're worried, and then we have to do the treatment anyway. And so sometimes you'll see us not even wait for the paired. So questions. Oh, I didn't even have that on here. So what do you guys think about when you're doing the workup for these kids who we say, this is a high-risk infant? Because you probably noticed that we all, not we all, in ID, there are different things that different people are doing and asking for. Yeah, you're thinking, Ismail's thinking, he's thinking.
I'm always thinking, because really with syphilis, I'm always confused, honestly. That's why we need your help all the time. Actually, one of the confusing things is whether to start treatment before the results are there or not, because sometimes it's taking a while until we get the results back, especially if the baby is not that much symptomatic. That's one of the things that really sometimes I feel weird.
Right.
Yeah.
I mean, the good thing is that you don't have to rush to treat. In other words, you can wait a couple of days. It's not urgent. It's not HIV or hepatitis, right? We have to act within the space of hours, ideally, to prevent transmission. So you do have time to kind of think about it. You don't have to rush to give the treatment before the results are back from the serology. And certainly it doesn't depend on the workup that we do. What I often think of and what's helpful is going kind of head to toe and thinking about all the different systems that might be affected by syphilis. And I can kind of give you a sense of what we've observed over the 7 years this has been going on. So when we go through the full head to toe, we think about the nervous system. You guys are involved a lot. You do a lot of LPs. We do see some cases of neurosyphilis. And if you think about congenital syphilis, it's symptomatic. It's analogous to secondary syphilis, meaning that it's dissemination of the treponines everywhere. Kids don't really have much of a blood-brain barrier, so we do see it, right? So the LP is important. We send that away for all the things you typically would, like protein, glucose, cell count. In addition, we're sending it for the VDRL. So this is the one time you're going to see the VDRL show up. And then it also goes over to the national lab for PCR. So we're looking for treponines directly in that sample. Likewise, if it's going to affect the nervous system and you're doing an LP, it makes sense that you can potentially have hearing and eye involvement. I did the opposite there. So eye involvement, hearing. And we do that all the time. To be honest, we have not found a single child with an ophthalmological finding. And that is actually something the ophthalmologists are looking at actively right now. Do we need to do that? And that's actually important, right? Because we like to think we're doing a lot of evidence-based medicine, and I will come back to this in a second. The hearing, yes, we do find hearing abnormalities every now and then, but it is so challenging to figure out what's causing the hearing abnormality. And I say that because often you get a package of women with syphilis, other STIs, substance use, poor nutrition, and all of these different factors going together. So I don't know you can tease out that it's necessarily syphilis by itself doing that. The nose is something new. We started doing that back in, I want to say 2017, where we're looking, because one of the most common things you see is about a week after birth, snuffles. So it's usually these incredibly mucopurulent hemorrhagic secretions that come from the nose. And as you know, PCR is such a sensitive test, we thought maybe we can pick it up early if we were to swab in areas, just like we're looking for COVID or RSV. And we found that about 40% of kids actually will have that. So it's a very useful exam and test to send away to look for it, because that helps us confirm, right? If it's there, we know what it is. It's confirmed congenital syphilis. Likewise, we kind of move downwards. Some of us will get a head ultrasound. I don't tend to. Some will ask for an abdominal ultrasound looking for hepatosplenomegaly. I depend on physical exam for that. Blood work like you normally would, because you can absolutely see, especially in your NICU patients, really sick kids who in fact are anemic and thrombocytopenic. On occasion, you'll even see leukopenia. Hepatitis is not unusual to see, again, when you have these kids admitted to NICU. A chest x-ray is helpful, particularly when you need ventilatory support, and in otherwise, you would say more term infant. And I say that because you can actually have pneumonia alba, which is a syphilis disseminated infection in the lungs. And then, of course, x-rays. X-rays are probably the single most useful thing that we do in terms of trying to find and confirm these cases. Because I'd say 40% or so will have some bony abnormality. And our radiologists are becoming so good at it that they're actually looking now back at all the previous cases we had and going, I don't think that actually really was a confirmed case, because typically when there are bone findings, they're bilateral and they're disseminated. So when you find kind of isolated findings, it's probably not really congenital syphilis. And there is a research project going on right now where we tried to figure out if there was any association between maternal and infant titers and bony abnormalities. There wasn't. And then we're now also figuring out if there's a way that we can come up with a better radiological assessment. And so that project is ongoing. The other interesting thing that we, go ahead.
Do those bony abnormalities go away?
100% they do. So we used to do x-rays on everybody who had bony abnormalities. And usually by 3 to 6 months, they were gone. In fact, they were all gone by then. And so we stopped doing it unless we saw serology wasn't going down. But serology not going down is the exception. Like we rarely, if ever, see it. And that's actually what led us to change our practice in another way. So what you see if you look at guidelines is that if the kid has evidence of neurosyphilis on LP at birth, you're supposed to repeat it at 6 months to document that you've actually managed to clear syphilis. What that led to was you had to, one, organize a conscious sedation, and you'd have to have somebody who was willing to do the LP. And these kids still were very difficult to get the LP on. And all the CSFs we got never changed our management. We were always like, this is a lot of organizing for no particular value. And so we started looking into the history of it. And I'll get to that in a second too, because that's my favorite part about all of this. And then finally, of course, there's the administration of penicillin. Yes, you can give a single dose of IM penicillin, which is analogous to primary and secondary treatment in adults. Does it work? It seems to. We don't tend to, though. Like on occasion, when we're like really on the fence about whether or not it's a high or low risk, give the IM, and then we'll follow them up. We tend to do 10 days of IV penicillin. And so that is the 50,000 international units, Q12 for the first 7 days of life, and then Q8 for the remaining 10 days. So like day 8 through day 10. The fact that I know that off the top of my head is sad, but that's what it is. Now, we were always wondering, because when you look at all of the guidelines, what they state is that standard of care. And so that's what they said about the LP, that's what they said about the ophthalmological exam, that's what they say about 10 days of penicillin. And so we were really curious to know why that was. And so Sergio Fanella, who's one of the other ID docs, is and has redone the CPS statement on congenital syphilis. And so the two of us, because of our different roles in these national advisory committees, we're digging into the past, trying to find, well, where is this 10 days from? So near as we can tell, you end up going into the library and you do this deep dive. You start in the 2020s, and then it says, look at this document from 2010. And you go to 2010, and then it says, it's from this document in 1990. And then you go to the 1990s. This is when you actually have to be in the stacks themselves to start pulling things out. And then it just keeps going back until about the 60s or the 70s. And there is some indication that we do 10 days of IV penicillin because the 10 days of IM penicillin we used to do as an outpatient wasn't adequate and was leading to neurosyphilis, which is why we did the LP. And that LP got transferred all the way through, even though the IV penicillin is so much more superior that you don't see failure. But it still doesn't help us know, where did that 10 days come from? We don't know. We can't find it. It probably was a bunch of pediatricians in a bar at one point talking and saying, hey, I think 10 days is probably the right amount.
I feel that the ID magical numbers are 7, 10, 14, 21. It's like
Well, it's because we work in a base 10 system and a week is 7 days. Like there's nothing, yeah. Like if we worked in a base 8 system, I suspect the treatment would be 8 days.
Yeah. So that is something that I think we may end up looking at a little bit here, saying, is this 10 days really necessary, or is this overkill? Because obviously to have these kids in hospital for 10 days receiving treatment when otherwise we wouldn't really keep them there, and getting a PICC line, I mean, I can tell you it costs about $13,000. And so that's not insignificant, right? That's a lot of money. And when you have 80 plus kids a year, that's a lot of cash, right? So anything we can do to prevent that and have public health interventions that are different or work differently, hell, we're all for it. But I also do appreciate where this randomness comes from. Like during COVID, for instance, we had MIS-C, right? And we were talking about, oh, what do we do for this? Well, it's kind of like Kawasaki's disease. And so if it's like that, maybe we should give IVIG and steroids. And I remember saying, when we had a hematologist, a rheumatologist, critical care doctors, myself, and we were having this discussion, I said, why don't we do it systematically and try to figure out what's making a difference? And we didn't. And so now the standard of care for MIS-C is IVIG and steroids. And it's not based on evidence at all. Like it is 100% expert opinion random. We just decided on it. And so that's where I'm like, that's where it came from. I am pretty convinced for congenital syphilis as well. So that's kind of the approach to syphilis in general. It really comes down to the most important thing is having that paired serology of mom and baby at delivery, going through mom's history, ensuring she received adequate treatment for her particular stage, her antibody response or her titers have come down appropriately, and then assessing baby, because on occasion you will say that baby has a rash and that looks like congenital syphilis. But by and large, like you guys, I said, by far you see the ones who are the most clinically affected. The majority of them are pretty asymptomatic and you're not going to find very much. So that is kind of a whirlwind tour of syphilis.
I have one more question.
I'm going to stop the share here. So
just I want to ask about the nasal swab or the nasal PCR. Is it nasopharyngeal aspirate like the one we do for bordetella pertussis, or no, it's just a swab? And how often, like, let's say, because what we are used to do is like just the serologist for the baby, but are we tending to do it like included in the package for the baby?
Okay, so the first question as to what sample to send, you can send either. I think the nasopharyngeal swab is probably better because of just the nature of the specimen. You have a flock swab which picks up more material ultimately, and so you can get that and send it to us. I don't think we have looked at seeing which sample is better, but because most of it what we have is nasopharyngeal swab. So theoretically, that is what I would suggest doing with swab versus an aspirate. You don't need to aerosolize syphilis. We also believe everything's airborne these days. So that's not funny. It's not funny. And the second thing, of course, is related to serology, and we're talking about the follow-ups, right? That's what you're asking about?
Like, because for the nasal swab, I witnessed just one time it was requested for one baby. Yeah. But for the rest, it was not asked. And even the nurses, like I was in St. Boniface, they were wondering what should we order? What should we do? Because it wasn't new for them. Right. But in one of the articles or one of the practices, it was an aspirate. And that's why I was wondering, it's very difficult, especially if the baby is not symptomatic, not like in the bordetella pertussis, how to get that secretions with the suction. Absolutely. And my other question is about like whether should we include it in the package we do with the serologist in suspected cases?
In the suspected cases, that is actually important. I was saying that this doesn't lend itself well to an algorithm to decide on high and low risk, but a standard orders set for those that we consider high risk absolutely makes sense. And that is something that's being worked on right now. But yes, it will be included there. I don't know that things like the head and abdominal ultrasound will be included. I leave up to the radiologist if they really think it's worth it. I haven't really seen enough abnormalities on either of those studies to convince me that it has utility for syphilis. If you happen to need to do it for something else, awesome, go ahead. The other thing I should have said too is that when we're talking about these high risk infants and their serological follow-up, we don't do the 1 month anymore because we found, again, it wasn't changing anything we do. We do the 3, the 6, and the 12 months only. So yeah, the serological follow-up is actually really important. I mean, that's where the one case where we kind of had a low risk who ultimately developed syphilis somehow was kind of a low risk. We followed up and it was only because of the serology suddenly just doing this big jump at 12 months, we figured out there was a problem. But the majority, like the rest of them have all been this really nice just decrease with a few that do progress to have where we say confirmed case. So these were infants who were completely asymptomatic at delivery. All the investigations were negative. We do serology up to 12 months, 15, 18 months. And we say, you know what, they still have antibodies, so that implies infection. The challenge there is that if we were to defer treatment for 1 month, we would probably find our confirmed cases in those high risk probable cases would all converge. They would all be real. So it's an interesting dilemma, right? Like, because we're treating them because we're preventing a confirmed infection. And then the numbers seem artificially low, and you saw that in the public health data, when in fact, no, they're real, but we just treated them and we aborted the serological response because we treated them so early. So it's a catch-22, hey?
I have a question.
Yeah.
for the LP. So we do the LP, but the treatment doesn't change, right? If it's positive or negative, and then you know that the CSF will clear up anyway, right? That's what you said. So why do we do the LP?
Yeah, that is the other question. I mean, that's what I was kind of alluding to, that we have, I'm not sure what the evidence necessarily is to support that. When they were treating these infants with maybe IM penicillin and you didn't necessarily get the same cure rate, that might have been required. But upfront, it can confirm the case. But ultimately, from a clinical perspective, I don't know that it has the same utility, because you're right. Like, does it change what we do? No, we're doing the exact same treatment. The follow-up we used to do at 6 months is now we don't do it. So it's a question of, should we continue to do that or not? And I think that there's a lot of opportunity for a lot of studies to figure that out here in Manitoba. And if we combine with Saskatchewan, who's seeing the same, about 200 or 300 exposed infants a year, with a third of them ultimately being infected, that's a pretty powerful study.
I have a second and last question.
Sure.
Because I do the high risk follow-up, and we started getting lots of those kids for long-term follow-up for developmental problems, and we decided it's overwhelming, and we decided to put some, like, a guideline to bring the numbers down. So, and one of the guidelines we said are those who have a positive CSF. But is there any evidence that those have more risk of having developmental or neurodevelopmental issues in the long term?
Right, and that's a tricky one, because I would say that of the CSF positive kids that I have seen, the majority fall into the camp of other things going on that requires them to be in your NICU. So the question is it the syphilis exclusively that would lead them to have these long-term sequelae, or is it that they were having a severe illness in general requiring critical support? And I don't have the answer to that either. I think that, again, it's probably multifactorial. I would actually have to look into the data further to say, like, is the isolated CSF in a treated kid associated with developmental abnormalities? Because that'd be hard. Like, I don't know how you would tease that out.
Thank you for the great talk. Hammam, I'm one of the fellows. I believe we met in the hospital briefly about a case. Thank you for the great talk. I've noticed your infographics, a lot of them are up to 2020. It'll be interesting to know how syphilis has changed in the COVID era.
Yeah.
And the
I
other
can tell you
question
right
is,
now.
and the other question is, I know you said it's probably like there's a lot of dilemma. If we were to put a time frame on initiation of treatment, because that's what we're mostly concerned with in NICU. Are we missing that window? Yeah,
and that's fair. In answer to your first question, what do we expect to see with syphilis now that clinical assessment, follow-up, and testing are kind of returning to more normal levels? I think you're going to see an increase overall. And we're also going to see an increase because with the dropping of restrictions in and around COVID, people are much more likely to be traveling internationally throughout Canada, the States, etc. And as a result, they're going to have more high-risk exposures ultimately too. So the numbers are going to only go up for the next little while. Where we run into interesting dilemmas too here in Manitoba is that we're far enough out now that we're probably going to start to see things that are tertiary syphilis in presentation. So if you think about those gumas that you historically heard about, like with faces kind of dissolving or the heart conditions, those are coming. Like, we're going to start to see those. That doesn't affect us in the pediatric world. The adult world has to be on top of that a great deal. And your second question, sorry, was about
a time frame for initiation of treatment?
So like I was saying earlier in the talk, that with HIV, right, we know we have to initiate it within about 6 to 12 hours for it to be optimally effective. And hepatitis B is very similar. This is, we have time. Like, you know what, you can, in theory, wait for those lab results to come back to help guide you one way or the other before you initiate treatment. But then there's also this great pressure, I understand, for discharge from hospital, and then this resistance to, I don't want to send them home unless I have this result back. And so that's oh, go ahead, Chelsea.
Just like logistically, like let's say it's Friday and the mom's still up north and we're keeping the baby, we're okay to wait until Monday till mom comes down to get serology. Like when you mean it's not urgent, we're talking like 3 to 5 days is okay?
It's fine. Yeah,
okay.
Absolutely. No, there's no issue with delaying that. I mean, the only issue really is related to that hospital pressure for getting through patients and getting them home.
But usually if we have them, they're with us for some other reason.
Exactly. Okay. It's more for the normal nursery, women's hospital, 4th floor, where they really are, they're frantic to get the results back. And that's something that we worked on fairly aggressively here at the lab. What we can control anyway. Once we have the specimen, getting it run isn't a big deal. It's getting it from there to here. And the black hole that was between the old women's hospital and here seems to have migrated as well to over there. So sometimes these specimens just disappear and we don't see them. So that's kind of the key thing. We have to have the specimens. They have to be labeled as kind of more urgent, and then we can get them done a little bit quicker to help with hospital flow for sure.
Okay.
So I know that
another STI for us.
What's that?
Do another STI for us?
I can, if you want, I can keep going, or I can come back for a full talk about HIV. Would probably be the big one to talk about. Or I could just do that like freestyle, because I talk about HIV all the time too. It's up to you guys. Like if you guys have a busy day and you want to carry on with your work, that's fine. If not, it would take me about 15 or 20 minutes to talk about HIV and kind of how we do a very similar approach to what we do with syphilis. But I wouldn't have slides. I do have slides somewhere, but I'd have to put them all together. I can't do that on the fly.
Well, why not? Because we have you scheduled for 90 minutes, and I don't think the fellows have another talk this afternoon, right? So could you give us your HIV quick and nasty, and then we will also schedule you. I'm scheduling for the next academic year shortly.
There you go. And this time I'll actually show up. I was that was very, very funny though, getting that call. Are you coming? It's like, I'm teaching right now, the med students. But anyway, so HIV is the other one that we are worried about here in Manitoba. And why that is, I mean, we're seeing an evolution of the HIV epidemic here in the province that is running in parallel with syphilis. So for the longest time, we were having pretty consistent prevalence overall. But what we're starting to see is that when you have women who are high risk for syphilis, their risk factors are the same as HIV, and now we're seeing more HIV in a younger population. That being said, it's odd that we're not seeing too many of them who have been coming for delivery and being picked up at delivery. But regardless, historically, we used to have women who would deliver, and if they were on absolutely no treatment whatsoever and we didn't do anything, what do you guys think the risk of transmission is to that baby? This is like the 80s, before we had pretty much any antiretrovirals at all.
I would throw a number of 2 to 3%.
2 to 3%. Okay, so I hear one vote for 2 to 3%.
Was it 20? I'm gonna throw 20.
20%. Okay, so it's closer to about 25 to 50%. So if we didn't do anything at all, it's basically 1 in 4 to 1 in 2 children would end up getting HIV from their moms. But again, this is important because it's before we had anything that we could do. The 2 to 3% we'll come back to in a second, because that actually was a valid number a little while ago. It's changed since. But of course, the big difference was the introduction of antiretrovirals. And so the antiretrovirals work in essence by decreasing the amount of virus somebody has in their blood. And why that's important is because that is the single greatest predictor of whether or not there's going to be mother-to-child transmission. The key part too is that there's really not much of a difference between someone who has a viral load of like 200, 300 and somebody who has 10,000. The risk is really not exponential. It's not really changing as much as you'd expect. The fact that they have detectable viral load is important. And it's also important to know if they've had detectable viral load across a longer period of time. So is there a higher probability of in utero transmission? But at delivery, the single most important factor is looking at the viral load, detectable or not. And the higher it is, probably the higher risk, but there's not a clear relationship with that. So once we actually introduced highly active antiretroviral therapy, and when I say that, does everybody know what that means? And it's okay if you don't, because HIV medicine is becoming to ID as ID is to general pediatrics. It's so out there. Hepatitis C is like that now too. It's like, what is going on in the adult world anyway? So
Isn't
when
it like it's like a whole bunch of different drugs on a very regular basis.
Precisely. So it is 3 different drugs from different classes that work in different ways on HIV to reduce the amount of virus that people have in them. And so it used to be we had these nucleoside reverse transcriptase inhibitors. So most people, when I say AZT or zidovudine, know what I'm talking about. But there's some others in that group too. The newest one, like if you got a needle stick right now from a mom and you went to emergency and you were worried, they would probably put you on tenofovir, which is a really good drug. It's newer, far less side effects, it works better. But we also have things like protease inhibitors. We have these integrase inhibitors as well. So it's basically a combination typically of 2 nucleoside reverse transcriptase inhibitors like AZT and lamivudine. So Combivir, if you might have heard of those. Or we use newer ones like tenofovir and emtricitabine. And then we add on a protease inhibitor or these integrase inhibitors. And so it's great because we used to have to give people 14 pills a day back in the 90s. And now we literally almost always have 1 pill once a day. And it's an odd statement, but I'll say it anyway. Like when I look at all these chronic diseases, if I had to pick between diabetes and HIV, I'd pick HIV easy. Like no doubt, because it is 1 pill once a day. I don't change anything about my life in any regard. So that's kind of the big step in. So once we had women on triple therapy and we introduced AZT to their babies, both during delivery and then for a period of time afterwards, what did that drop the risk to? So this is easy. The 2 to 3% that you mentioned back in the 90s with kind of the older antiretrovirals is a very accurate statement. Now with the new antiretrovirals, it's actually closer to about 1 in 1,000. So it's really, really quite low. And that's a couple of important caveats to make too. You have to have no breastfeeding and you have to finish the AZT. What changed in the past about 15, 20 years is that the duration. So about 10 years ago when I first started, 6 weeks of AZT was the norm. And usually what you would see is that maybe about a quarter to a third of kids would have this enhanced physiological anemia. So the hemoglobin is always going to drop, but it would do this really big drop, and that was directly related to AZT. So we started looking at the evidence a little bit closer, and in particular, what came out of the United Kingdom. So if you were to get your needle stick injury and go into the emergency and they put you on antiretroviral prophylaxis, what would they, or PEP, post-exposure prophylaxis, how long would that treatment last? So that's good. Nobody's had it happen to them. I'm impressed.
Or like, because if it's negative, you don't have to keep taking it, right?
Exactly. So
like I've been poked, but I've never actually had to take the prophylaxis.
Yeah. So if you go to the emergency department as like an occupational exposure, it's a 4-week course that we're going to give you, right? And so that was the thinking was, well, why do we give 6 weeks? Well, why is simply because that was the protocol that was studied in 1994. And so in the UK, what they looked at, they said, well, we know that occupational exposures are 4 weeks. We have enough infants who've been exposed, who've had to stop at 4 weeks. Do we see an increased rate of transmission if we compare the 6-week group to the 4-week group? And lo and behold, no, not at all. The only thing you see different is less side effects. So that's where they said, okay, well, then we can probably get away with the 4 weeks. And that, of course, is all in the low risk exposed infant. So that is like I'm saying, a mom who is taking all her antiretrovirals. She has a consistently decreased viral load. She's not going to breastfeed after. And we give AZT at delivery and then for the baby for 4 weeks. That's when we say it's 1 in 1,000 right now. Where we run into trouble is when you have a woman who, one, comes in, doesn't know she has HIV, so she has lots of virus around. Or we also have women who know they have HIV, but ultimately they are struggling to continue to control their disease well. If you remember, I was talking about crystal meth earlier on. So crystal meth is an interesting drug in that you're high for 8 to 9 hours at a time. So that severely interrupts your life and dysregulates everything. And in fact, a lot of women who had HIV who were addicted and using heroin didn't seem to have the same problems using their antiretrovirals that women on crystal meth do. And so that's led to a number of women who would be considered higher risk. They're not taking their medication consistently. And as a result, they were having higher viral loads. So what have you seen us do when these women come in? We know that they either you diagnose them because you did the HIV point of care test, and you're like, damn it, we didn't know this person was positive, or you found out this woman hasn't been taking her drugs for 2 months for whatever reason. What has ID come along and said, hey, this is where we're going to start?
You're going to call ID and give whatever drugs ID tells you to give.
Yes, whatever we say. And that's really accurate, right? I'd say that, so AZT is kind of the cornerstone of treatments for prevention in these babies, and it actually becomes a treatment for them of choice as well. So the only difference here is that we will actually do triple therapy, which is analogous to what we give to in heart, right? So we throw on the nevirapine, we'll often do 2 weeks of that, and we also throw on the lamivudine for 2 weeks as well. So the idea there is to try to provide the best potential opportunity to prevent transmission. And when we have kind of these higher risk scenarios and we use all those drugs, the risk of transmission is around 5%. So it's not bad. It's still not as good as 1 in 1,000, but it can work. And we definitely run into adverse drug reactions with this medication because, you know, that's 3 different drugs, all kind of potentially affecting bone marrows and hepatotoxicity, etc. What was I going to get at here? Now, what often happens too is we try to figure out when did these babies get infected, and that's why we do a lot of follow-up. So we do follow-up at 2 weeks of age, at 1 to 2 months of age, and at 3 to 4 months of age. And we have to use nucleic acid amplification tests specifically, because if we were to test them serologically, they are positive. And they are positive with our new serology tests for at least 15 to 18 months. So that's why we're doing that. And if we're worried and we're saying this is a high risk scenario, we actually do it right at birth. And the reason for that is that if it's an in utero transmission, then we actually put them on treatment, which is almost the same, but it's a little bit different. We still use AZT. We're still using lamivudine, but we may continue with nevirapine at a treatment dose, or we may switch over entirely to another drug like Kaletra. Or what we've been doing a lot lately is giving them raltegravir. We've had 2 kids on that. In fact, we were one of the first centers, if not the first center to do that. So we beat Toronto, we beat Sick Kids, and I was very excited. I was like, yes, we're the first ones. Regardless, it's a lot better tolerated. It's a good drug. Because if you were to try Kaletra, Kaletra is like, I think 30 to 40% alcohol. So it's like a shot, basically, these kids are taking, and you can see their reaction. At first, they don't like it. When they're older, they do quite well. The big issue I think that has come up from HIV perspective is, believe it or not, the breastfeeding. And so we, as the Manitoba HIV program, will provide formula to moms who will have that for the first year of the baby's life. And that's a really big incentive. And I know that the obstetricians will also give medications which basically make milk production go to 0 in the nursing mother. But we've had about 3 or 4 women in recent months who, oh, sorry, go ahead, Chelsea.
No, yeah, you might answer my question, but before we finish breastfeeding, I have a question if you don't answer it. So finish your spiel and then I'll
Sure.
ask my question.
So yeah, we've had about 3 or 4 different women who are asking for whether or not they can breastfeed now, because they're saying that I'm on HART, so I'm on my triple therapy. I've been suppressed the entire time and often for years. And so then if I know that, and they're hearing this, and this is a very valid message from the adult world, undetectable equals untransmissible, then why can't I just breastfeed? And so that makes sense, right? It's true that if you in fact have no detectable viral load, the chances of you transmitting sexually are remote. It doesn't happen, seemingly. But when we're talking about breastfeeding, you have to remember that breast milk has different components. There's kind of the liquid component, and then believe it or not, there's a cellular component, including lymphocytes. And so if we are to compare a person's serum viral load, and they're undetectable, it means that the liquid component of breast milk will in fact be undetectable too, but the cell-associated component will have integrated HIV into it. So knowing that, and then also thinking, well, if you're breastfeeding, you are breastfeeding every 2 or 3 hours, and you're doing that for weeks and months on end. And so cumulative risk increases, because I'm guaranteeing that there is nobody who's having sex every 2 or 3 hours for 3 or 4 months. If there is, I suppose the risk might be increased. But the point being that, that's a pretty tough situation. The other thing, of course, is to consider that, there certainly is a stigma associated with breastfeeding or not breastfeeding in certain groups. So when I think of HIV in Manitoba, we have our Indigenous population. And so I would say it's more common to have almost shared care within the family. So formula feeding seems to be a bit more socially acceptable versus our African New Canadian population, where the whole idea of not breastfeeding is associated with the fact you would have HIV, because why else would you do it? And so they really want to be able to breastfeed. And so Indigenous women haven't tended to ask about breastfeeding, but we have had some African women who do specifically. And they also know that, wait a second, when we were back in Rwanda or the Congo, we could breastfeed. So why are we not breastfeeding here? And so the World Health Organization absolutely suggests that, if the risk of dehydration and malnutrition is greater in those particular resource limited settings, sure, go ahead, because otherwise this baby is going to simply die. But here we provide formula. And so it's a different scenario. And usually when you have this discussion saying that, if you are to breastfeed, it's about a 1% to 2% risk of transmission. And so that's not insignificant, right? And that would also mean that if you did it, we would like to know, because we would be monitoring very closely. We would consider, do we have to give antiretrovirals to your baby? And even if we do, is it going to stop this? We don't know. And there are centers too, like in Toronto, that have done a few women they've supported through breastfeeding. What makes it even more challenging is that social media, you actually have HIV positive pregnant women and mothers who talk to each other from all over the United States and Canada, who are hearing, wait a second, this center is supporting it, but this center doesn't. So it's an interesting message to have to convey. And so I think that we are giving a talk, Vanessa Poliquin and I, in, I don't know when it is, November, I want to say, where we're talking about breastfeeding and HIV specifically. So if you want to join for that, because we've had now 4 consults from women specifically. And the good thing is that when they're provided with all that information, that you're going to get formula provided the entire time, the risk is not 0. And that the rationale for doing it in the more developing world is to support hydration and nutrition. They've all said, no, we're absolutely going to do formula feeding only, because I don't think there's any woman who wants to give HIV to their baby, right? The interesting thing too, and this is more an ethical dilemma, at least when I think about it, is, I mean, the difference between a sexual partner and your infant is vast, right? Your infant has no choice where they get their nutrition from. And I actually even called CMPA when we first started having these consults to say, what is my medical legal risk if we support women who want to provide like breastfeeding for their babies, if this infant gets it and then at 18 decides, I'm going to sue the doctors and the system that allowed that to happen. CMPA, in their usual vague advice, was kind of like, that's why you document absolutely everything you do very, very carefully. So they're not saying that you're free of risk, it's fine. They're actually saying you could be, and you are going to have all of that documentation exceptionally clear. So that is kind of a whirlwind through HIV. We determine basically low and high risk. The most important factor to us is antiretroviral compliance or adherence and the viral load at delivery and throughout the pregnancy. If they're low risk, ACT for 4 weeks with typical follow-up 1 to 2 months, 3 to 4 months. We do another one at about 12 months to 15 months, but that's serology. And if they're high risk, we do a test immediately at birth. We provide triple therapy. And then we do the follow-up a little bit more extensively, because back when I first started as staff in 2010, we got burned by this one kid who was a higher risk scenario, and we happened to test them at the 5-month mark, and we found their viral load was about 200, and we were like, oh, maybe that's a lab accident. And when we brought them back a week later, their viral load was 1.2 million. So we actually just caught them as they acquired the infection, and so that's why we do one extra test a little bit later for them. In terms of the, sorry, I should have said the number of HIV positive kids that we have here. Oh, I think there's about 20 now, and the last transmission was in 2020, like in December, no, 2021. It was just this past winter. And she was unique in that this tells you racial profiling and biases on my part, 100%. I walked in the room, I knew the kid had HIV and syphilis, and it was a little blonde, blue-eyed kid. And I was like, wait, am I in the wrong room? But in fact, no, this was a kid who happened to be a white kid. So we don't see too many of those, to the point where I said, I thought I was in the wrong room. So they all do quite well, to be honest. We have them on their antiretrovirals. They're in usually foster care if they're Indigenous. If they are Black, African, they tend to be in the care of their parents still. The biggest challenge, honestly, is when you get to about age 8 to 10, the disclosure process. The challenge there is that they don't know. They don't know why they're coming to CID, right? They just know they have an infection, they're taking some medicine for it. When they can start to read, that becomes a problem, because they can read what's on their medicine bottle. And as you know, these kids are very good with computers and the internet, and they can look it up. And so it's hard to keep it away from them at that point. And then the other challenge we run into is during the teenage years. Like any other chronic disease, they do not want to have a chronic disease, and they tend to go off the rails. So it's often hard to get them back into taking their medication as consistently as they should. And they also obviously have the problems. If you think back to your teenage years and adolescence and all the problems that you had, imagine having HIV on top of that, and even considering any sort of dating or romantic options. It makes it that much harder. And then the final thing that we have is the transition. When we transition kids from the adult world to, or pediatric world to the adult world, they don't like it. And that's true of any sort of chronic disease as well, because we're a lot more hand-holding, but it's not even the hand-holding for HIV. If you think of what HIV is in the adult world, it's a different creature, because these are in every way, shape, and form completely just normal kids who happen to have HIV, and that is not the case when they go to the adult world. They sit in the waiting room and they're immediately like, oh my God, this is a mistake. And then they'll come back almost always and talk to us and say, I don't know about this. And you're like, I get it. So anyway, that's hopefully enough room for questions there as well.
Yeah, just one small question about the use of point of care kind of test they do in the labor and obstetricians they do. So how much it's like, let's say it gives a positive predictive value, or like it's valid, so that I can rely on it, so I can start the treatment based on it.
Yep.
What if it's negative and the real status that mother is sick or having
Right.
HIV?
So when we're talking about the HIV point of care test, yes, it is available at the Women's Hospital and St. B in the triage, and the nurses have had the training to be able to administer it. It's not very complicated to use. When we're talking about the sensitivity and specificity, it is 99.7% and 99.5%. So I obviously talk about these a lot. So they are very sensitive and very specific. The only time when you would really be worried is if you have someone who might be acutely seroconverting, and that would imply that they don't have antibodies to HIV yet. In which case, that would be maybe the 2 to 3 week window after the exposure. So if you knew someone had a high risk exposure and it was 3-4 weeks before, and you have a point of care test that's negative, you may want to say, you know what, I'm going to actually send normal serology on them, because what we do here is a combo antigen antibody test. So if you happen to be in the window period, you're going to have lots of virus, no antibody, but the lots of virus is going to have lots of antigen, and we're going to pick it up, and we can advise you appropriately. So the HIV point of care test is overall excellent, unless you have that one kind of very close window to exposure.
And then just to follow up, because Jared, you and I had this discussion and I didn't know, is we had a case where we had a pregnant person that had a lot of high risk behaviors, but she was not in the hospital. And so we actually did the point of care test on the baby to decide whether we needed to continue the baby's prophylaxis. And I mean, I don't see any, when I think about that, I can't figure out why I would have thought that wasn't possible, but it was, I mean, it's certainly an option instead of continuing meds that often make the baby super pukey.
Absolutely. And I think that's completely fine. Like, we have used it in babies a fair amount, and their antibodies are going to be the same as mom's, right? Again, the only issue would be that if we had a high risk mom who just got HIV, in which case we probably wouldn't know from her point of care test either. We would just make the executive decision to say we're treating this baby and I don't care. So, all right. Oh, sorry.
Sorry, Jared, I have a question regarding the HIV treatment for babies. Is it different if the baby is preterm?
Yes, in terms of the frequency for the AZT, but I don't remember exactly what it is. I think that when you look at the standard order sheet, it will tell you based on the different weeks of gestation. But yes, it is different. You are correct.
Yeah, there's a standard sheet at HSC and there's a standard order set at St. B.
Thanks, Jared, for this excellent presentation. It takes me back to the Concord study, my first is end of my residency, my first fellowship, and that changed the numbers of HIV from 25% down to 2 to 3% at that time. And it's great to see that now we're down to 0.25%. Like, it's fantastic.
Yeah, thank you. There's work to do. There's still work to do, but yeah.
And we don't have, I was reading, there's a depot. There's a depot treatment now, isn't there? Or is it just still in studies?
There have been depot treatments for a while. They're just not, it's kind of the patient background and what that population is like are not so likely to continue to come to get their once monthly or whatever it is shot, right? But yeah, we have a couple of different options that are coming as well. And they're always looking at new drugs. The amount of new medications in HIV medicine is impressive. And it's actually like, it's hard to keep up. For peds, not as much, because they don't trickle down to the young kids very effectively. But once they get to a certain age and weight, you can actually start to put them on some pretty reliable meds. Like, most of our kids who are in their like preteens are on Biktarvy, 1 pill once a day. And I know that we have our one kid who I've seen since I started, who's she's 17 this year. Ooh, she's old. Yeah, but she is the one who struggled with the 14 pills a day. She was just like, this is ridiculous. And I'm like, here, 1 a day. And she's like, what is this? That's not fair. I'm like, it's not my fault. I didn't do it. Any other questions for me?
Sorry, regarding the syphilis patients, I was just thinking if there is any correlation with the congenital syphilis and development of pulmonary hypertension. Just like we had 2 cases with severe pulmonary hypertension. I couldn't find something solid in literature. I don't know if you have any further data or details about this.
I haven't seen that. As I said, all I know is that when I have a congenital syphilis case in the NICU, they're usually very symptomatic. And I think the kids that you're talking about have been the sickest ones I've seen by far, with the exception of one at St. B a couple of years ago.
And sorry, regarding the long bone X-rays also. So I understand that I think we are doing it as part of the diagnosis. I think so. If we don't find long bone changes, would we need to repeat the X-ray? Does it have a certain time that it should appear?
No, I don't expect it to show up. And even if it were there and we repeat the X-rays later, it's resolved typically. In fact, we even have, and we were wondering about this, is we have these kids who may have been infected in utero. Mom got the treatment, they had bony changes, and then like they're born 2 months later, and we X-ray them, and we're going, there's X-ray changes consistent with congenital syphilis, but is it because they have the infection from delivery, or is it because of what they had before? And we're not sure how to parse that out. But in the end, no, you don't need to repeat the X-ray just by virtue of looking or to look for it. It's fine.
Thanks a lot for your time.
Oh, my pleasure. I'm glad I could make this happen today. And yeah, if you have any other questions, let me know.
Yeah, thanks. And yeah, I'll be, once I sort my life out, we'll be looking for the fall. So, I mean, I'm sure a full.
You can sort my life out too.
Yeah, I'll send it to your admin. She can sort your life out.
Yeah, hopefully.
Okay. Thanks, Jared.
You're welcome. Take care, guys.